Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 331 of our pharmacotherapy series, which majors in diabetes mellitus. The first question relates to patient SLH from parts 329 and 330 of this pharmacotherapy series. Which other antidiabetic agents could be considered for SLH as monotherapy if she cannot tolerate metformin therapy? Although the ADA recommends the use of metformin, in combination with lifestyle modification, as first-line therapy, other antidiabetic agents are approved for use as monotherapy as well. SLH is a typical overweight type 2 diabetes mellitus patient with early evidence of cardiovascular disease, that is, hypertension, but with no evidence of microvascular complications. Her liver, renal, and GI functions are normal. Patients like SLH have varying degrees of beta cell dysfunction and tissue resistance to insulin. In these individuals, pulsatile insulin secretion and first-phase insulin release are absent, and the pancreas is blind or unresponsive to high glucose concentrations, that is, glucotoxicity. Because target tissues are less responsive to insulin, hepatic glucose output typically is increased and higher concentrations of insulin may be needed for peripheral glucose utilization. Insulin causes more weight gain and hypoglycemia than the other antidiabetic agents and is usually reserved for combination therapy unless the initial A1C at diagnosis is very elevated, that is above 10%, or ketonuria is present. Often, acarbose is eliminated from consideration because slow titration is required to minimize GI effects. Anecdotally, however, people of Mexican-American origin, such as SLH, seem less susceptible to flatulence and diarrhea. Also, because acarbose has less dramatic effects on the fasting plasma glucose, that is 20 to 30 mg per deciliter decrease, and A1C 0.5% to 1.0% decrease than the other agents, biochemical goals are less likely to be achieved in patients whose A1C is 8.5% or higher. Pioglitazone also can be used as monotherapy, and, like metformin, will not cause hypoglycemia, but weight gain and edema are likely. On the positive side, the thiazolidinedione have been shown to have better glycemic durability compared with metformin and the sulfonylureas. In a double-blind, randomized, controlled trial of 4,360 patients with type 2 diabetes mellitus, time to monotherapy failure, defined as fasting plasma glucose greater than 180 mg per deciliter, was assessed for rosiglitazone, metformin, and glyburide, a diabetes outcome progression trial abbreviated as ADOPT. Patients were treated for a median of 4 years. The Kaplan-Meier analysis showed that the cumulative incidence of failure at 5 years was 15% for rosiglitazone, 21% for metformin, and 34% for glyburide with a p-value less than 0.0001. The suggested explanation for the favorable rosiglitazone results was that it slowed the rate of beta cell function decline. On the negative side, thiazolidinedions are associated with many adverse effects including an increased risk in bone fractures and heart failure. Thiazolidinedions are associated with an approximately twofold increased risk of heart failure and thus are contraindicated in New York Heart Association Class 3 to 4 heart failure. In the long-term ADOPT trial, rosiglitazone was associated with a mean weight gain of 4.8 kg, whereas weight decreased by 2.9 kg in the metformin group. Gleburide-treated patients had a mean weight gain of 1.6 kg during the first year, and then remained stable. The thiazolidinedions also have been found to reduce bone density and increase fracture risk. Given the adverse effects associated with thiazolidinedions, and the availability of other agents, the use has fallen out of favor. Sitagliptin, saxagliptin, and exenatide, which are approved for monotherapy, are often reserved for combination therapy. However, dipeptidyl peptidase 4 inhibitors may be useful as monotherapy for patients in whom the use of other oral agents is precluded, such as renal dysfunction with metformin or severe heart failure with pioglitazone. Glucagon-like peptide 1 receptor agonist may be particularly useful in obese patients. It should be noted that AACE recommends glucagon-like peptide 1 receptor agonist as first line if metformin can't be initiated first. Finally, one should not forget that until the newer agents became available, sulfonylureas were used quite successfully to treat obese patients with type 2 diabetes mellitus. Although these agents are relatively effective with an average A1C reduction 1% to 1.5%, there are still several issues with this class of medications such as unfavorable adverse effects, such as hypoglycemia and weight gain, durability issues, and may worsen the lipid panel. Although the use of these agents has fallen out of favor due to these effects, they are effective and often utilized when cost is an issue. Several products that combine two oral agents into one medication are available. Although many of these products are approved as first-line therapy, thus skipping the monotherapy step, consider reserving them for use in patients who are already established on the two agents or whose medication regimens must be simplified to enhance adherence or decrease cost or are already established on the two agents. Based on this discussion, metformin is favored as initial therapy in SLH. The next question reads, KNH is a 46-year-old, obese man, with a BMI of 33 kg per meter squared, with a history of type 2 diabetes mellitus, and hyperlipidemia. He presents with complaints of fatigue and nocturia. KNH used to smoke 2 packs of cigarettes per day for 15 years, but he quit after his diabetes diagnosis. He has a strong family history of coronary heart disease. At diagnosis 3 months ago, an elevated A1C was documented, 7.6%, confirming the diagnosis of type 2 diabetes mellitus. Tests of liver and renal function are within normal limits. Current medications include lisinopril and atorvastatin. KNH started metformin but stopped taking it because of GI symptoms, that is, loose stools. He refuses to try this medication again. What is a reasonable next monotherapy option for KNH? Unfortunately, KNH did not tolerate metformin. Although this is less common if patients take metformin with food and the dose is titrated slowly, some do not overcome the GI adverse effects. KNH is refusing to even consider a retrial. An A1C goal of less than 7% may be appropriate for KNH, although given his young age and long life expectancy, a target of less than 6.5% would be preferred. Therefore, the A1C lowering required to get to goal is only 0.6% to 1.1%. With a BMI of 33 kg per meter squared, hypertension, and dyslipidemia, KNH has many components of the metabolic syndrome and insulin resistance. Sulfonylureas or insulin would not be an optimal next choice of drug for KNH because they do not exert a favorable effect on plasma lipids and generally are associated with weight gain and hypoglycemia. Also, his A1C is not high enough to need insulin therapy yet. However, it must be acknowledged that some sulfonylureas remain the least expensive oral antidiabetic agents, and this may be an important factor in the initial selection of therapy for some patients. Picarbose as monotherapy is not likely to attain near normal plasma glucose concentrations. Given he is obese, and likely insulin resistant, although pioglitazone improves peripheral target tissue responses to insulin and lipid profiles, avoiding pioglitazone due to adverse effects of weight gain is prudent. A glucagon-like peptide-1 receptor agonist, dipeptidyl peptidase 4 inhibitor, or sodium glucose cotransporter 2 inhibitor are reasonable options for KNH because they are not associated with weight gain. Glucagon-like peptide-1 receptor agonists and sodium glucose cotransporter 2 inhibitors may even promote weight loss. For KNH, initiation of a glucagon-like peptide-1 receptor agonist, such as liraglutide, is a reasonable option. A glucagon-like peptide-1 receptor agonist, along with lifestyle changes, should be able to get to his A1C goal. If liraglutide is used, it should be initiated at a dose of 0.6 mg once daily for 1 week and then increased to the therapeutic dose of 1.2 mg once daily thereafter. Some patients may require further titration to 1.8 mg once daily in order to reach the glycemic goals. KNH should be counseled about the likelihood of GI side effects, which should subside over time, as well as the rare risk of pancreatitis, and to stop taking and notify his provider if he has persistent severe abdominal pain that may radiate to the back and vomiting, and severe allergic reactions. KNH was successful in reducing his A1C to 6.4% through a combination of lifestyle modifications and sitagliptin. He was able to lose 10 pounds with walking and reduction in fatty food. KNH quit smoking 3 months ago. Smoking has been shown to increase the risk of impaired fasting glucose and type 2 diabetes mellitus. The mechanism for this is thought to be related to increased insulin resistance and oxidative stress and reduced insulin secretion. Smoking also increases the risk of microvascular and macrovascular disease in people with diabetes. Therefore, KNH should be congratulated on his cessation, and continued abstinence should be encouraged through follow-up visits. The next question reads, QRP is a 68-year-old woman, whose height is 5 feet 1 inch, who weighs 155 pounds with a BMI of 29.3 kg per meter squared. She has an 8-year history of type 2 diabetes mellitus. She has been treated with diet, exercise, and metformin. According to clinic records, she was well controlled initially with an A1C 6.7% to 7.2% for the first 5 years. When her glycemic control worsened, that is a fasting plasma glucose of 130 to 160 mg per deciliter. A1C, 7.5% to 8.5%. Her metformin dose was increased from an initial dose of 500 mg twice daily to her current dose of 1000 mg twice daily. Recent chart notes indicate that QRP's chief complaints have included loss of appetite and fatigue. Her current A1C is 8.4%. Other medical problems include hypertension managed with hydrochlorothiazide 25 mg daily and mild peripheral neuropathy managed with acetaminophen 500 mg twice daily. Her eGFR is 70 ml per minute. At this clinic visit, QRP, who is well known to you, seems particularly listless and flat in her affect. Her blood glucose records, which are typically meticulous, are incomplete. AM fasting blood glucose values consistently exceed 200 mg per deciliter and range from 202 to 340 mg per deciliter. While taking her history, you discover that her husband passed away last year and that one of her adult children has recently been diagnosed with a terminal illness. What factors may be contributing to QRP's poor glucose control? Several factors may be contributing to QRP's deteriorating blood glucose control and apparent lack of responsiveness to maximal dose of metformin during the past year, as evidenced by her elevated blood glucose and A1C, listlessness, and lack of appetite. Monotherapy failure, also called secondary failure, is characterized by progressively poor glucose control that occurs after a period of good response, that is, for months to years. The cause of failure may be related to progressive pancreatic failure, poor adherence to diet, exercise, or medications, and exogenous diabetogenic factors such as increased weight, illness, or drugs that induce hyperglycemia, e.g., atypical antipsychotics or glucocorticoids. Type 2 diabetes mellitus is a progressive condition, which is most likely to require combination drug therapy. The UKPDS confirmed that monotherapy failure represents a natural progression of type 2 diabetes mellitus. In this study, only 16% and 19% of the subjects achieved a fasting plasma glucose less than 108 mg per deciliter and A1C less than 7%, respectively, after 3 years of dietary therapy alone. By 9 years, only 9% were able to maintain the glycemic goals using just diet therapy. The investigators also found monotherapy failure occurred at the same rate regardless of the initial treatment selected: glyburide, chlorpropamide, metformin, or insulin. In all the monotherapy treatment groups, patients required additional therapies over the course of the study duration. At 3 years, fewer than 55% of patients randomly assigned to single pharmacologic therapy could maintain an A1C less than 7%, and by 9 years this dropped to about 25% of patients. In the ADOPT study, patients were able to maintain A1C levels less than 7% using monotherapy for 60, 45, and 33 months with rosiglitazone, metformin, and glyburide, respectively. The reason for glycemic deterioration is likely owing to the natural progression of type 2 diabetes mellitus, in which beta cell function declines with increased duration of disease. QRP's deteriorating control on a therapeutic dose of metformin after 5 years of reasonable response is consistent with the natural progression of type 2 diabetes mellitus. However, the stress and depression arising out of her life situation have no doubt contributed to her poor control. The latter may have led to a change in her usual adherence to diet, exercise, and medications, and should resolve with time and appropriate management. Women with type 2 diabetes mellitus are at increased risk of depression. Evidence exists for a bidirectional association between diabetes and depression in women. Although hyperglycemia has been attributed to hydrochlorothiazide, the dose prescribed for QRP has few adverse metabolic effects. The next question reads, how should QRP be managed? What is an appropriate antidiabetic agent to add? QRP is exhibiting symptoms of depression, e.g., listlessness and flat affect. Her depression likely started after her husband's death. Every effort must be made to address QRP's depression because it is unlikely that she will be able to effectively implement more aggressive treatment of her diabetes mellitus until her situation is improved. Resources that may be used include her family, a therapist, and a social worker. Treatment of monotherapy failure includes identifying and correcting any diabetogenic factors and altering her drug therapy. When failure to any oral agent occurs, one should always add another agent rather than switch to another, unless adverse effects are intolerable or contraindications warrant the discontinuation of the drug. This is supported by a study that evaluated the effect of metformin alone in a population of patients who had failed oral sulfonylureas and the effect of metformin plus the sulfonylureas. Substitution of metformin for glyburide did not produce any significant change in glycemic control, but the addition of metformin to glyburide therapy substantially improved glucose concentrations. Many combinations of antidiabetic agents can be used. The key is that they should have different mechanisms of action. For example, it is not reasonable to combine a sulfonylurea with a glenide, i.e., repaglinide and nuteglinide, because they are both insulin secretagogues. Options for QRP include adding one of the following to metformin: insulin secretagogue, sulfonylurea or glenide, acarbose, thiazolidinedione, e.g. pioglitazone, dipeptidyl peptidase 4 inhibitor, e.g., sitagliptin, linagliptin, allagliptin or saxagliptin, sodium glucose cotransporter 2 inhibitors, e.g. canagliflozin, dapagliflozin, or empagliflozin, or a glucagon-like peptide 1 receptor agonist, e.g., exenatide, exenatide ER, albiglutide, dulaglutide, or liraglutide. Sodium glucose cotransporter 2 inhibitors should be used cautiously in this patient because this drug class is associated with genital mycotic infections and urinary tract infections. One also could introduce insulin therapy at this time. However, because QRP's A1C should be effectively lowered to less than 7% with an additional non-insulin agent, 2 non-insulin antidiabetic agents should be utilized. In summary, patients such as QRP who are unresponsive to the maximally effective dose of metformin should be initiated on combination therapy. The next question reads, as anticipated, QRP refuses to consider insulin therapy at this time. Which combination of antidiabetic agents is preferred? When agents from different antidiabetic classes are combined, their effects are essentially additive. With the availability of many antidiabetic agents, there is no one best combination therapy. As discussed, the choice of therapy should take into account the patient's organ function, amount of A1C lowering required to reach an individual's goal, possible adverse effects of a particular drug or drug combination, cost, and patient preference. A mixed treatment comparison meta-analysis evaluated the efficacy of second-line antidiabetic therapy added to patients on stable doses of metformin. The risk of weight gain and hypoglycemia was also determined. A total of 27 randomized controlled trials were included in the analysis, with a mean study duration of 32 weeks. In addition, the change in A1C depending on the baseline level of A1C was evaluated and found, as previously discussed, to be greater when the baseline A1C was 8% or more. QRP is concerned with the costs of her medications, and brand drugs have a higher copay in her insurance plan. QRP would like to remain on oral medications if possible. Because she is postmenopausal, avoid a thiazolidinedione owing to the concerns of increased risk of fractures. Given the significant GI side effects associated with the alpha-glucosidase inhibitors, the use is often avoided altogether. Dipeptidyl peptidase 4 inhibitors are available by brand only, so initiating a generic is an option. Therefore, she is started on glimepiride 2 mg orally daily. The next question reads, QRP is titrated to glimepiride 4 mg per day and continued on metformin 1000 mg twice daily. This improved her fasting plasma glucose and A1C modestly for approximately 12 months. Fasting plasma glucose 120 to 150 mg per deciliter, currently A1C 7.6%. She remains resistant to starting insulin, despite repeated counseling. She has heard about a new, injectable class of diabetes medications that cause weight loss, and asks whether she is a good candidate to start one. It quickly becomes apparent that QRP is referring to the glucagon-like peptide-1 receptor agonist, exenatide, exenatide-ER, dulaglutide, albiglutide, and liraglutide. Only exenatide is on her health plan's formulary. When the A1C is above goal despite the use of a combination of two agents, practitioners often add a third agent before considering insulin. Although this is tempting, depending on a patient's current level of glycemic control, this practice only delays insulin therapy, which is likely to be required to achieve A1C goals. However, because QRP is close to an A1C level of less than 7%, it is reasonable to try a third, non-insulin antidiabetic agent. Although glimepiride 8 mg per day is the maximal dose, there is little difference in clinical efficacy compared with 4 mg per day. Therefore, increasing glimepiride to 8 mg per day is not likely to achieve her glycemic goals. Exenatide is approved for use in patients as monotherapy and also for those taking metformin, sulfonylurea, or a thiazolidinedione alone, or a combination of metformin plus a thiazolidinedione or metformin plus a sulfonylurea. When added to patients on a sulfonylurea and metformin, exenatide at 10 micrograms twice daily resulted in a 0.8% A1C reduction compared with baseline. Thus, for QRP, the addition of exenatide could result in an A1C of less than 7%. The use of exenatide with a sulfonylurea is associated with an increased risk of mild to moderate hypoglycemia, 28% when used with sulfonylurea and metformin and 36% when used with sulfonylurea alone. Most practitioners reduce the dose of the sulfonylurea on initiation of exenatide and then make adjustments based on the patient's response to exenatide. QRP should be started on exenatide 5 micrograms subcutaneously twice daily, taken within 60 minutes of the two main meals of the day and at least 6 hours apart. She should be counseled about nausea, which is the most frequent side effect. 44% of patients will experience nausea, but there is only a 3% dropout rate in the clinical trials. The glimepiride should be reduced to 2 or 3 mg per day to avoid hypoglycemia. After 1 month, if she is tolerating exenatide, the dose should be increased to 10 micrograms subcutaneously twice daily. Her A1C should be monitored within 3 months of using the 10 microgram dose. An advantage of exenatide versus dipeptidyl peptidase 4 inhibitors is the potential for weight loss. In a 30-week blinded study of exenatide added onto sulfonylurea and metformin, patients on the 10 microgram dose had an average weight loss of 1.6 kg. In the 3 open-label, uncontrolled extension trials with exenatide, at 3 years, exenatide progressively reduced that is negative 5.3 kg, and sustained weight loss. QRP should be counseled about the rare risk of pancreatitis. Also, if she finds that nausea is significant enough to reduce her fluid intake, she should contact her provider. The FDA has received case reports of altered renal function and renal failure with exenatide, which are likely owing to dehydration from reduced fluid intake because of the GI side effects, i.e., nausea, vomiting, and diarrhea, caused by exenatide. In patients with significant GI side effects, reduced fluid intake, or pre-existing renal dysfunction, the serum creatinine should be monitored more closely. Exenatide should be used cautiously with moderate renal impairment and is not recommended in patients with creatinine clearance of less than 30. A small proportion of patients will form anti-exenatide antibodies. At high titers, these antibodies could result in failure to achieve adequate improvement in glycemic control. If there is worsening glycemic control or failure to achieve targeted glycemic control while on exenatide, the formation of blocking antibodies should be considered as a reason. If this occurs, it may be reasonable to switch over to another glucagon-like peptide-1 receptor agonist or exenatide ER. It is important to note that any of the available glucagon-like peptide-1 receptor agonists are options for QRP for initial glucagon-like peptide-1 receptor agonist therapy. Discussions should be regarding adherence, efficacy, side effects, and cost. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 332.